Hi, we're going to talk about population health. You're getting this lecture following our in-person session and orientation. So this is meant to kind of fill in the gaps that we weren't able to cover in class. As part of that flipped classroom, this will be kind of the process. Next week, you'll actually get the online lecture prior to the next course or the next lecture. So um, and then Dr. Murnell and I will be switching back and forth. So you'll have a mental health section next week, and then I will see you again in week 3. So we need to talk about population health and how we focus on prevention, look at how communities participate, and then how do we as population health nurses actually focus on those educational strategies. So we know that public health nursing has a really significant focus now because there's been a renewed interest in public health as well as population-focused healthcare, mostly because of improvements in prevention and healthcare related to the Affordable Care Act. Uh, Between the Affordable Care Act and the U.S. Preventative Services Task Force, we've seen a significant increase in a population-focused approach, an emphasis on prevention, so getting people before they become ill or injured, and recognizing that public health nursing does have a significant role, that this is an opportunity and a challenge for them to combat the costs of healthcare, to serve the needs of a changing U.S. Demography, and also to look at what is our role in bioterrorism and epidemic prevention. So we've seen issues with Zika, as well as measles, which is hitting close to home. So this is where public health and public health nursing comes into play. We know that although not every event is absolutely preventable, there is a preventable component to each of those. And we'll be talking over the coming weeks about primary, secondary, and tertiary prevention, which is defined as the anticipatory action taken to prevent the occurrence of an event or to minimize its effect after it has occurred. We will have done a primary, secondary, tertiary activity in class, and then we'll come back and we'll talk more about this in week 3 and week 5. This is also something that you are introduced to in your NS 315 course as well. The benefit of completing prevention or prevention programs is that we can reach large populations, we can work on affecting change, we can promote awareness of the issue, whatever that issue may be, and also promote a commitment by not just the health system, but also the people in the community. When we reach out to larger groups, we actually promote an increase in cost efficiency, and it gives us an opportunity to evaluate how effective that might be. Population health is really looking at a focus on what's considered a free living client, those individuals who are not part of a health facility. So these are not people who are in the hospital or an assisted, or I'm sorry, they might be in assisted living, but they're certainly not going to be in a facility of some sort. So they're living in the community and they may or may not have some level of health, which we'll talk about in just a moment. We know that prevention work has the greatest impact on the biggest majority of people, and those happen to be also the ones who are free living and those who are interfacing between their health and health practices as well as where they live. Populations need to be defined, and there's a couple of different ways that we can define them. They can be groups of people. They can be groups who live in defined geographical areas, can be groups who share a common culture, values, or norms. They might have a shared social structure. That might be a long-term community-specific social structure, or it could be a modified one. Often we know that the members of that community have a shared personal social identity because they have beliefs, values, and norms in common. And we also look at defining them by people, place, or function. We sometimes call them populations or aggregates or even subpopulations. So those collections of individuals who have one or more personal environmental characteristics in common, geography, special interests, circumstance, that could be, where they live, it could be residents of the state, it could be residents of a location like the Mat-Su, or people who actually live within the city limits of a particular town. They could have a special interest or circumstance, could be their age, could be their gender, could be the type of work that they do, or a hobby that they might have. We also sometimes call them subpopulations, so we could be talking about all the people who live in Anchorage and then a smaller group like teenagers or sexually active teens. We could be talking about people with diabetes in Anchorage. So we can look at them a number of different ways. We also have to look at them specifically based on how they define their own health. So they can be clinically healthy in that they're not diagnosably ill or injured. They could have health related on their role performance. So let's say the mom or the farmer who might have a chronic illness or a broken arm and is still able to complete their daily tasks. They might be adaptively healthy, so those people who require a hearing aid or a wheelchair to function independently. They could be eudaimonistically healthy. Those individuals, I liken that to the very top tier of self-actualization and Maslow's hierarchy of needs. Not everybody gets there, but there are those people who are there. And we're talking here individual health, but also community health. I mean, there may be groups of individuals in Anchorage or in a particular location who their health is related on their ability to function in their role, whether it's a fisher or a hunter or a miner or a nurse or a doctor. And it's all of those. Are they able to function in that role? Versus the individual miner or farmer or mom who's has defined health. Our community's health is really reflected in the behaviors and the outcomes of those behaviors that's practiced by people who live in that community or participate in that community, and also by the ability of that community to support those healthy individuals. We know that individuals often have very dynamic interactions between the social and environmental features of their communities, and we're going to talk more in the future about the socio-ecological model. One of the things that I do is I have a Prezi called The Determinants of Health, and we want to look at what's involved. So we're looking at what's involved with those specific social determinants of health. And so the World Health Organization says that those are the conditions in which people are born, grow, live, work, and age. It includes, the economy, it includes resources, and we know that it includes a lot of different things. If you're very interested in these determinants, then I highly recommend that you take a look at Unnatural Causes. And so they have a number of different documentaries that highlight issues like poverty and racism, and I can't remember, I think there's 4 or 5 of them, and there's one that's like an hour and a couple of them are 30 to 20 minutes. So that's certainly an option. We're going to watch this little video.
Give me your poor, your tired, your huddled masses, the poem goes. Today, many new immigrants to the U.S. are still poor and tired, but they're certainly not sick. In fact, they may be healthier than the rest of us.
They're doing something right. We have to understand what it is and try to spread that benefit to a larger segment of society. That's the lesson that immigrants teach us in public health.
But the good health many immigrants arrive with comes with an expiration date. Instead of improving their health, life in the U.S. often has the opposite effect. Within a generation, they see their health advantages undermined by the same social forces that erode the health of all of us.
As these new Americans become more like old Americans, they get unhealthy.
So when we think about this socio-ecological model, we have to really think about health in a new way. There's an upstream, downstream adage about people falling in the river, and we're so busy trying to help fish them out downstream that we forget to walk upstream and find out why people are actually falling in the river. Um, we know that health begins not just at the doctor's office, but where we are living, where we learn, work, and play. We know that everyone should have the opportunity to make the choices that allow them to live a long and healthy life, regardless of their income, education, or ethnic background. Our neighborhood or job shouldn't be hazardous to our health. And the opportunity for health actually starts long before we ever need medical care. And it also begins in our families, our neighborhoods, our schools, and our jobs. There's a number of social determinants of health, and part of the socio-ecological model looks at those levels. We start at the individual level. It's those biological or genetic pieces that we can't change, right? How old we are, how many kids we've had, where we were born, what birth order we were born in, what our education level is, what's our employment, are we married or not? Do we have the ability to make uh, decisions in our life, whether that's jobs or health or anything else? The next level is the household or family, because we know that individuals live within family systems, and so depends. There could be 2 people in the family. There could be more than 20. How many kids? How many people have jobs? What kind of assets do they have? What's the social status, racial status? How many people who live in the household actually have schooling? Our communities, are they rural or urban? How developed are they? Do we have a wide spread of individuals from different social, cultural, and economic levels, or is it a very homogeneous community? Are there health resources that are available? Are there jobs available? And so, and how does that impact us? Nationally, where do we live? How big is our population? How wealthy is um, our system? So how wealthy is our country, like the U.S. versus, say, a country like India? What kind of governance? What kind of health system do we have? Are there jobs? Are there health services? And is there a look at healthcare reform if that's necessary? And then, of course, there's always the international levels that impact us. And so globally, what's the economic situation? How is trade? What's the dominant ideology between nations? What are the dominant feelings about healthcare? And how are human rights also parlayed into this discussion about population health? We know that meeting the needs for populations is often called upon by public health nurses, and so we've been doing this in the United States since the early 1900s. And what we know is the American Public Health Association talks about the role of nurses and their ability to take that information about health and illness experiences of individuals and turn around and talk to health planners and policymakers and other people in the community to become a voice for the issues of those vulnerable persons and help to make change for those vulnerable persons. And that's actually the focus of this capstone project, because it's what are we doing and how are we going to get there? And as nurses, we have to understand how those social and physical factors interact with both the individual level, who somebody is, male, female, age, those kinds of things, those things that we can't change, and how do we then design an effective intervention to help improve health outcomes, but also look at interventions and policies that maybe look upstream. As public health nurses, the focus has traditionally been on healthcare to communities, and those individuals have that very specific hands-on knowledge about who lives there, and this makes them really suited to participate actively in bringing public health research into practice. And this is probably one of my most favorite public health videos. So we'll watch this. So that is the Prezi that I typically do, just to kind of review the upstream, downstream introduction, and then also cover what the social determinants of health are. And so looking at them from the cultural side, but then also all of those, that public health in action video actually covers very specifically those health behaviors that may actually be involved. So then we have to talk about, so how does this differ between populations and individuals? And so what we know is that we diagnose, intervene, and treat situations or issues for entire populations or subpopulations, and we might do this at the primary, secondary, or tertiary level. When we're looking at the larger overall groups, our decision making is definitely different. We have to look at vulnerabilities, we have to look at funding, we have to look at all those different kinds of things. And so one of the big issues is that we're often thinking about the biggest bang for the most, the biggest bang for your buck. And so how are we doing the most for the sometimes limited amount of money that we have? And so, and how do we stretch that across multiple subpopulations, as opposed to the individual focused practice where we are looking at diagnoses, interventions, and treatments for a single person, and how is that best suited. So again, we're talking about the collective or common good of the population, not the individual. It's definitely a much more complex change process. And while we can be doing direct nursing care as part of that population focus, a lot of times that's not how it is. And so an example would be the municipality of Anchorage has direct nursing care as part of that public health department. But if you look at the state of Alaska Public Health Department, there's significantly more limited direct nursing care. There's itinerant nurses that do go out, but the majority of their work is done at the larger state level. There are some specific core public health functions, which we'll actually talk about in the next lecture in week 3 on assessment, assurance, and policy development. The role that you have as a nurse is to look at building credibility and trust, not just at the individual level like you already have, or not because everybody knows that nurses are trustworthy, but working at the community or population level by being a gatekeeper or by working with key informants and other individuals so that you can work outside of just that one-on-one space. A lot of times public health nurses they gain an insider status so that they maybe have a diverse background and then do outreach to other communities, and so they have specialized training to reach out to the AIDS population or specialized training to reach out to victims of violence or other specialized training so that they can meet very specific subpopulation needs. And remember, when we're talking about promoting healthy communities, the whole is greater than the sum of its parts. And so if we affect a change in one part, we are actually changing all the other parts. But we can't do this without collaboration and without feedback. And so what we often find is that if we're making a change to one subpopulation, that information can often be fed back to the overall community. Sometimes if we're looking at just working with, say, teens or like promoting don't drink and drive to a smaller teen group as opposed to the entire population, that those teens then feed back that information to their larger group because they go home and they talk to their family, they talk to their peers, they get older and talk to their peers as they age. And so again, that's a feedback loop. And so this creates opportunity for change or course correction. So do we have a community that has decreasing issues with drunk driving, or do we have a community that has decreasing issues on texting and driving because of that collaboration and change that we are using to promote a healthy community? We use Healthy People 2020 to promote our goal of health outcomes for populations, and we're going to talk about that specifically in the in-person section in week 1, and we'll have some activities to do that. I highly recommend that you review Healthy People 2020. Go to that website. There's a significant number of objectives that really provide systemic approaches to health improvement. And so like if you're interested in health education, there are Healthy People 2020 goals and objectives which focus on that. If you like evidence-based practice, there's goals and objectives for that. If you're interested in reproductive health or child health or maternal child health, men's health, any topic, chronic disease, vaccines, all of that, that's all listed in Healthy People 2020. And it's amazing because what it does is it looks at where are we now and where would we like to be in 10 years. And for us, we're heading into 2020. This is 2019, right? These goals were actually developed in 2010 for 2020. And so the 2030 goals are actually in development now. So part of what we do is, as public health nurses, is we look to make change by assessing our communities. So just as you assess, remember ADPI, just as you assess your individual and work to help them make health-related goal changes one-on-one, we're doing the same thing with communities. And so we have to start with assessment. And so we're going to take a detailed stock. We're going to look at that community from the inside and from the outside. Sometimes we call it community needs assessment, but we're looking at all different kinds of data and we're making a judgment once we have clear knowledge and understanding of that community. We can't know who that community is until we actually look at what information is out there. We have to get out there and learn what our community is or who they are by maybe doing a windshield survey, by literally boots on the ground, walking around, um, looking at and seeing what's there and what are we identifying as community problems. We're gathering data. Maybe we're looking at census data, or we're looking at survey data of like individuals in a subpopulation or a larger population. We're developing a database between what we're seeing, what we're finding, what we're being told, what the research tells us, and then we're going to interpret that database in order to identify problems and strengths, and then analyze those problems and strengths to figure out what the next steps are. So why do we do this? We need to know what the needs are in that community and what their strengths are, and then confirm that data so we can address that recognized problem. And so public health nurses are what we consider an ideal assessment leader because they have this broader knowledge of the community process, and they're bringing that forward so that we're not just looking at it from that individual level, but from that larger population standard. So, and what we want to do is we want to balance community health problems with community health strengths, and ideally decrease the problems and increase the strengths. And so maybe we're going to do informant interviews, focus groups, observe people, walk around, community reconnaissance, collect reported data, surveys, census, those kinds of things. And then again, develop that composite database that we talked about already. Some of those data sources might be things like websites or printed materials. And again, key informants or focus groups. You might be using GIS to look at where populations are identified, just all the different pieces that you need to kind of move forward. It might be primary data. It could also be secondary data. And again, remembering that the whole is always greater than the sum of its parts. And so when we affect change in one, we affect change in the others. So one of the things you're going to do when you're getting started is you need to identify a model that's going to guide your assessment. And we often talk about like the socio-ecological model, which is coming up in just a minute. You have to actually visit and interact with the community and with people in that community. And then you have to collect data, right? Who are they? Where do they live? What do they do? And in the real world, you're going to want to do this for a month or more to get a good feel. In our project, you're going to have 6 weeks to conduct your project. However, there are 7 or 8 of you in your group, and so you're going to be working together to do that. And we'll talk more specifically about that in your seminar sections. One of the things that a lot of times public health nurses do is, because it can be difficult to get information, is we'll work with community coalitions. We'll include stakeholders. So we invite people in the population of interest to come and talk to us, because sometimes it's easier to talk with them and they're more willing to talk with us than, say, individual members of the Hmong community, but we might talk to a Hmong community group if we're trying to work with that particular population. This might be parents in a PTA group, as opposed to trying to get a hold of every parent that has kids in that school district. It might be the parents who are participating in PTA. Windshield surveys are some of the things that we often do. It's a simple observation giving us a quick overview, and we look at trends and stability and changes, and by driving and also walking areas of the community, we can see different dimensions of that community of life, right? So what is the housing quality? What are the geographic boundaries? Where are the gathering places? What do we see people doing in those locations? So those are some of the direct activities, the surveys, windshield surveys, talking to people that you may participate in, but there's also theories that are essential to help guide you as you move through these processes. And so theories are helpful because they give us a roadmap. They help us make assumptions about behavior or health problems. They're logical. A lot of times they're consistent with what we're actually seeing. You may choose one because it was used in a previous program and that was successful. And so you're replicating that. But it really is a systematic guide to help understand, explain, or predict events, and it illustrates relationships between the different concepts, right? And again, that roadmap. So, what are the dynamics between health behaviors, the process for changing influences, and identifying target audiences? So, we'll move into another Prezi here. So we want to talk about the purpose. And so it's really important that we have some kind of model or guide that helps us figure out what's going on because we want to identify um, a way to figure out what the basic causes of the problem that we're looking at. We want to be able to guide the interventions to make change, develop evaluation, but also explain behaviors. And so is this theory that we're going to use, is it explanatory? Does it tell us why this is happening or what can be changed? Or is it a change theory? Is it something that helps guide us as to what kind of strategies to use or messages? Or is it a mix of the two? And so, and sometimes we use it as evaluation, sometimes we use it for planning. The focus that I want you to have is that um, for theories is they are a guide to what it is that we're actually doing. So one of the things that we've looked at is back in the 50s is when they first tried to really understand why people didn't adopt a prevention strategy or engage in screening. And so one of the thing is so if you think about 1950 and cars and seat belts and those kinds of things, or smoking, right? We had to figure out what did people perceive the threat to be, what do they expect the outcomes to be, and then do they feel that they have the ability to carry out the recommended action? And so we had to look at all these different pieces. And so a lot of the original research was very specific about this as the behavioral model as to how we actually made or encouraged people to make change. It's very limited in the ability of to make change because it's very specific to what people's attitudes and beliefs are and their habits. You know, it was very socially acceptable to smoke in the 50s, and so it may not have been something that they perceived that the problem of smoking was that a problem because it was socially acceptable. And it assumed that everyone had equal access to the ability to wear a seatbelt or have a seatbelt. You know, a lot of cars in the 50s didn't have seatbelts at all. So we moved from that into something called the theory of planned behavior because it not only looks at is there a perception of the ability, but it also looks at the prediction and explanation of a behavior, which really, when we can predict or explain what's going on, we can look at areas where we can encourage change. But we do recognize that it still does require that the individual or population be motivated and have the ability to make that change. So there's a significant interaction between their beliefs and attitudes and what the community or their social group has and how much control they have over that behavior. And those all interact to form the intention, and then that is what actually causes the behavior change. It certainly has its own limitations. It assumes that the opportunity to make a change and resources to promote that change actually exist. There is a concern about fear, threat, and mood related to that experience, but it also doesn't give us a time address between the intention and the behavior change. And that's important because some of the theories that followed actually looked at the time factor. Bandura in the 80s looked at social cognitive theory, which really was a dynamic and reciprocal way of looking at how people acquire and maintain a behavior within their social environment. And it let us look at how they initiated a change, how they maintained that change, and how they controlled it. This one has limitations because, as you can see, there's not a whole lot there. It's very loosely organized. So, and it's really doesn't give us an idea of how influential each factor is. Doesn't look at motivation or emotion. It's actually very broad. It doesn't make it wrong. It's just a very broad option. This is probably a model that you guys are most familiar with is the trans-theoretical model or stages of change. This one has 6 stages. There are some time limitations, anywhere from 30 days to 6 months between the different stages. It's very cyclical. You can enter this. You typically enter at pre-contemplation, but you can exit and re-enter at any stage in the future. So if you think about somebody who is trying to quit smoking, they're thinking about their pre-contemplation. So they haven't even started thinking about it. Contemplation. They're thinking about quitting smoking. Determination. Now they're saying, I'm going to quit smoking, right? Then they actually take the action to quit. They may have a relapse or they might not, right? May move from action to maintenance. If they relapse, then they have to go back into kind of that contemplation or determination stage. Maybe they go from relapse back into action, right? Because they're like, oops, I shouldn't have done that. I'm quitting smoking today, right? Relapse, back to action, hopefully back to maintenance. But so this is a pretty powerful one, very specific to the individual, a little bit harder to apply to the overall population. And it does have some limitations. You know, it ignores the social context. It does assume that people are very logically planning to move through a health behavior change. There's a sociological model where we recognize that behaviors are influenced and reciprocal. They're very dynamic, and that they're systemic as well as interacting. So knowledge, attitude, and skills by the individual, you know, can impact that social network, can impact or be impacted by social networks, environments, cultural values, system policies. That might be government, it might be society. Kind of depends on how you're looking at it. There are some limitations because it's really unclear where culture, social class, gender, and economics may fit. Depending on who your author is, the meanings for each of these may change a little bit, and I'm actually going to show you that in just a moment. There's also a newer model, 1999, but models and theories take a really long time to develop, and it's called the integrative model for community health. It basically is the sociological model applied to this kind of spectrum of illness, health promotion, and prevention. And so it kind of lets you see that continuity of care, gives a basis for collaboration. And you can see it's a little bit on the confusing side. A lot of times it takes time to really kind of think about and where are the intersecting components. And it assumes that there's complexity, which when you look at the diagram, it's definitely complex. So again, it comes back to what is it that we're trying to do? Are we trying to explain why or what can be changed? Are we trying to look at what strategies or messages will work to promote change? And you know, and are we evaluating after we've done something? Or are we planning to evaluate? And so we'll talk about evaluation in week 3, so don't worry about that so much as right now. Looking at, are we trying to explain what's going on? Are we trying to identify the strategies and messages that will work for change? So this is another way that we look at the sociological model. Actually kind of like this one a little bit better because it talks about the individual and the focus on personal change, right? Relationships, individuals make up relationships, relationships and individuals are part of communities. All of those are then part of institutions and then society. And so, if we're trying to focus on changes in relationships, we're looking at relationships, right? Positive and negative. If we're trying to make changes in a community, perhaps we're looking at promoting a comprehensive health. Are we building bridges between institutions? Are we trying to look at norms change? So the example I give for norms change is movies, right? We went from not having movie ratings at all to now we have a wide range of movie changes. And so it's just a given now for kids to go to the movies and know that they can't get in to see, um, NC-17 or a rated R, right? Another example I give is also movies, but smoking. Think about movies that are out there and how many people you actually see smoking in a movie, unless the movie's about like the 70s or the 50s, then everybody smokes, right? If you watch older movies, pre-70s, everybody's smoking. And it's like you will actually find yourself going, wow, I didn't, that's a lot of people smoking. But that's a norms change that, we've, as a community and as individuals and as society, we've recognized that smoking is bad and we should stop. Another way to look at this is the sociological model, but broken down even farther. And so that we're looking at the life course, we're incorporating that in there, and we're breaking it down from not just social relationships, but into living conditions and neighborhoods and institutions. And so just different ways of looking at very much the same thing. If we're trying to make change and we're trying to focus on strategies, which is one of the things that you're going to be doing as part of this capstone, is are we trying to change their behavior? Or are we trying to change the environment? If we're looking at promoting individual behavior change, we're looking at the ecological level, right? Or even the relationship level. And so we might use theories such as these: stages of change, precaution adoption, health belief model, theory of planned behavior. If we're looking at specifically doing immediate advocacy, that's really the ecological level. So if you were going to develop a PSA about trail safety, that may very well be a community level change strategy, right? It's more about the environment than it is around behavior. And you're going to look at communication theories to really interact and focus how you're going to get that message across. So speaking of messages, we get our message across in public health nursing through health education, and particularly health education to groups. And so this particular quote talks about patient groups, but you could be talking about, groups at a community center or groups at a health fair, any number of things. And what I like about this quote is that he actually says, teaching specific groups requires a lot more than just delivering data. You have to really understand where your population is coming from. And as he says, that is a challenge. We'll be moving through into education intervention. And so you'll be having your intervention as a population-based health fair promoting summertime safety. So you're going to be looking at things over the next couple of weeks as how do people learn, how to be an effective educator, and what is actually that education process that you'll undertake. So we know that the easiest thing to change is knowledge. Then once people have knowledge, then the focus is to work on changing attitudes, because the hardest thing to actually change is the behavior. And we know that there's a difference between education and learning. And so, and we'll talk about that a little bit more later. So we know that people learn by hearing a message, by observing others, or observing an activity, by participating in an activity. And people who are learning, they accept what they're learning based on what they already know, what they believe, their culture, their ability to understand, and their ability to relate to that. And so we will actually look at some of these as very specifically. And so we'll have some activities that'll help you understand those pieces. And you'll actually put this into play when you're doing designing your intervention for your booth. As you've learned in prior classes, there are 3 domains of learning: cognitive or thinking, affective or feeling, psychomotor, and acting. And we know that they have a hierarchy of levels underneath each of those domains, and that those levels then build on the previous one. And our goal is to focus on motivating that adult learner. Your cognitive domain, first thing you have to do is assess that person's ability to understand. Do they have good literacy? Do they have health literacy? And so this is your memory, reasoning, application, and problem solving. Your affective domain, how are we working to change their attitudes and their values? And the biggest issue is that your attitude as the nurse working them may differ very significantly from their social or relationship values. And so we have to listen very carefully, because it can be really hard to change a deeply rooted attitude or belief or interest or values. And we know that people receive, respond, or value. They analyze, synthesize, and they have to do all of those before they actually adopt. Psychomotor domain is the use of neuromuscular coordination and motor skills. And so people will demonstrate, then practice, and then actually do. They have to have the ability, they have to have a sensory image, they have to have opportunity. Sometimes we do this by observation with one another. So, if you're trying to teach somebody how to use a bicycle helmet, a lot of times you do that by demonstration and then practice, right? There are some Healthy People 2020 objectives for health education. They give you guidance on developing community-based health education programs. They help you identify learning theories, educational principles, issues that you might have. They help you with design and implementation as well as evaluation. So I highly recommend that you look at those objectives. We know that as an educational process, you have to look at what are the needs, identify goals and objectives, select educational methods that'll work for this group, think about who you are as an effective educator, identify whether or not you need the motivational interviewing. That's more of a one-on-one type of concept, but you might find yourself using it, and then being able to develop that program. So you're gonna, the purpose of doing the community assessment is to also help you identify what their educational needs are. And so you'll often ask these questions as part of your surveys. And so you're going to prioritize what the needs are, if there's any barriers to those, and then you're going to develop those broad long-term goals with specific short-term objectives that can be measured. You need to match the educational method to the client and the presenter's strengths and needs. So if you're talking about a health fair, there are going to be some things that you're not going to be able to do, like show a video. You need to give some variety, and variety by what I mean is like cognitive, psychomotor, affective, not 5 activities that are all the same, maybe not 5 activities. Bringing in new forms of information or new ways of providing that information can often be very successful. And think about the age and gender, culture, knowledge level, and size of the group that you're going to be working with. Are you working with people one-on-one, or would these be small groups or larger populations? The educator, the person who's doing that work, needs to be able to gain the learner's attention, let them know what the objectives are. Do they have any prior learning? And if they do, to recall that. They have to be able to present that information and help their learner apply it. And then if there's an opportunity to demonstrate what they've learned, that would be great, and then give them feedback. So a lot of times at a health fair, you might have somebody, talk about what they're wanting to do. You might demonstrate something that you're doing so that it makes them apply it. And then you'll talk to them about, well, yes, that's a great answer to that activity, and this is what we might see instead. So this is where things like games like, Jeopardy and spinning a wheel and different physical activities may actually help do that feedback piece for you. Motivational interviewing may not actually be something that you're going to do as part of a larger population group, but just so you know that it's important that when you are interacting with people in the community as part of your assessment is that you are being engaging, you're asking open-ended questions, you're empathically listening, and you're reflecting back and giving a summary of what it is that they have talked to you about so that they know that you have heard them. When you're developing that educational program, you really want to make sure you're focusing on clear messages, clear language, and that you're tailoring it to the learning format. And we'll actually do this part from box 16-2 in class. So, and you'll get a chance to practice this also in your seminar. There are some issues when we're talking about doing educational activities, and so what are the population issues? Is there an age and generation strategy that you might want to think about? Are you providing pedagogy or andragogy? I remember pedagogy because it's pediatrics, child, so it's like how we teach kids, right? You can't teach kids fractions because they've never had fractions before, so you have to build on what they've already learned, versus andragogy, which is adult education, andragogy, adult, right? So we're building on all those other pieces that they bring all these other pieces to it. Their attitudes, their beliefs, their prior learning, not just about fractions, but their prior learning about, you know, English and work and home and other people. And so adult education, very much like what we're doing with you, is that we're building on all of these other pieces. We also have to think about culture specific and making sure that we're culturally competent when we're presenting any written, audio, or visual information, but also our literacy. If there's going to be technology that you're using, this is why we use PowerPoint, right? Because it helps control the pace of instruction. Technology gives us some flexibility in time and location. Sometimes it's appealing, sometimes it's not. Depending on what we're using, it might give us some immediate feedback. I like to use a lot of different things, but if you are using the internet, whatever that may be for your teaching, make sure you have evaluated the reliability and quality of your sources. There are different barriers, whether it's the educator related or learner related. When we're talking about educator related barriers, we're talking about the ability to speak in front of a group, right? Because that can be definitely very challenging if you're not comfortable speaking with a group. And so how are you then getting to that point where you're able to do so? And for people who are really uncomfortable, or they have a fear of public speaking, or they lack credibility, then, or they can't deal with people in the audience, that can actually be a barrier to the other people who are in the audience. And so if you're a new educator, getting feedback, having support, those are important things that you're going to put into place to help you get better at becoming an educator. Learner-related barriers are those things like they have low literacy or low health literacy. They might have a lack of motivation to learn information and actually make those behavioral changes. So that's one of the things, like when we talked about the health belief model, is that there was no real focus on motivation. So it basically was, if you give them knowledge, you tell them smoking is bad, they're going to say, oh, smoking is bad, and then they're going to stop smoking. But we know that's not really the case. And so that's the best example that I give people about that one. Sometimes it's really great to use groups as a tool for health education. We're doing that with you guys as Learning the Capstone and the Community Assessment Project. But you can also may find yourself working with groups. And so it's really important that you understand how groups work. And so you'll be talking about groups more specifically in your mental health section. But what are the task functions? What are their norms? What's the structure? What are the stages? And I know that you've had the forming, storming, norming, performing, and adjourning, stages information in the past, and we'll actually be watching you and walking you through those pieces. If you do opt to use a community group, you actually have to begin work on the stated purpose. Like you have to help them understand. You have to help them interact. You have to pay attention to how well they're attending or getting information. So that's a lot of times when as a faculty member, I'm in the front of the classroom and I'm asking you questions and do you understand that, or trying to get you engaged with me. I'm trying to pay attention and making sure that that you are there and you are heard. We know that conflict can be normal in a community group. You know, some people may be obstructed or irritated by others, right? And sometimes people will express those frustrations and sometimes people won't, and there can be conflict. The key is to be able to acknowledge that conflict and work towards that problem solving while respecting all members. And so we will be working with you as faculty in the community and mental health side to make sure that to help you through that process. So we'll end this part of the online lecture with just this quote from the same instructor who says, teaching specific patient groups is not just about what they need to know, it's also about what do they think they need. If you're not in tune with their concerns, you're not going to reach them. And so we want to help you be successful at reaching your audience, however we happen to go about doing that. Thank you, and I look forward to seeing you in week 3.